Okay, I think I'd like to get us started this morning. Welcome, everyone. Thank you for joining us today for a discussion in key trends in healthcare plan design. I'm Ann Donovan, president of Xenium HR, and I'll be having a conversation here with our friends from Regents, Renee Balsiger and Holly Kramer. Before we get started, just a few housekeeping items for today. We will have a webinar scheduled for about 45 minutes. We'll have the content and exchange for about 30 minutes, and then we'll leave time at the end for some Q&A from the group. You can enter your questions in the chat window throughout the presentation, and we'll keep our eye on it. If there's something relevant to the topic that we're discussing, we'll try to catch that and do it in real time. We will make sure that the slides and the recording is available to all attendees at the end. And we'll have a survey following the end of the webinar. So please give us your feedback, content, ideas for future webinars. We appreciate it all. And then keep your eyes peeled for alerts from us around new events, webinars, and content by subscribing with xeniumhr.com. We love to have you join us for these types of events. All right, well, let's get started. So Renee and Holly, if you will, share a little bit about yourself and your role at Regents.
Sure. So Renee Balsiger, I am the Director of Sales at Regents. I've been in the organization for a year and a half. But prior to that, I was in healthcare consulting with a large firm for over 19 years. So bring a good market view to Regents that is like the non-Regents kind of view that has really helped as we are developing programs and working with our customers. So it's been a super fun year and a half, even though the majority of this year has been at home, but we're hanging in there.
Good.
Holly?
It has been a fun year and a half with you here, Renee, I must add. I'm Holly, and I've been in the industry for 20 years. Man, that sounds odd when I say it. And I've been with Regents for just over 4 years. And I must say, I really do love working at Regents.
Awesome. Well, welcome to you both, and thank you for being a part of this dialogue. I know that this is top of mind for all of us. That we're in this unprecedented year. We're all in these unique circumstances, and healthcare is one of the biggest line items on all of our operating expenses. So I know that we'll have some good questions. We've got some great things prepared for you. So let's jump in. To ground us all in the topic today, so the attendees signed up for this session in hopes to unpack these trends in healthcare design. I'm excited to share some data that you recently released in a benchmark report, Regents did. But before we dive in, can you just share a high level what you're seeing in the marketplace as it relates to employer decisions around healthcare, kind of 10,000 foot view?
Sure, I'd be happy to. And I know we'll get to Holly and all the good stuff on data in a moment. But when I think about, decisions around healthcare, of course, there's three things that are so important to employers. And those are, of course, cost and benefit design, as well as stability of the program, especially during these COVID times. We're looking for a program that meets those basic needs, but employers are thinking beyond that now. They're thinking, how do I empower my employees to make good healthcare decisions, not just for themselves, but for our plan. And so they're really looking at programs that have tools and resources that are built into their programs to help their employees be more engaged in their healthcare journey. And I think about this, think about what we buy on Amazon right now. We go to Amazon. Here's a perfect story. So I just, on Prime Day, I wanted to buy one of those Roomba vacuum cleaners. And I'm like, okay, what kind should I buy? So before Prime Day, I got on, I did my research, what good features, what's my price point, what are the reviews like? And I did all that for a vacuum. And I'm thinking, okay, we need to do that for our healthcare. Am I Am I seeing the right provider at the right time for the right thing? Did I research these providers? Did I research the services? Do I know how much these things cost? And it's really important that we help our members engage that way. So employers are looking for tools, built-in tools, cost estimator tools, pharmacy tools, not just for pricing, but just to make sure that we're not having issues with interactions in our medications. They're for plans that have convenience, like telehealth, of course, super important, and we'll talk about that in a little bit later. So the virtual. And then another thing is a strong behavioral health benefits, and not just the benefit design, but access to those benefits. And we might talk about that in a little bit more. So really looking for a plan that encompasses all of those things, keeping in mind the cost and the benefit design and the stability. So that's a very broad overview of what we're seeing our employers looking for. So marry that with all the data that Holly is going to share with you now. And I don't want to steal her thunder, but I will say Regence being a large carrier in Oregon, we have over 800,000 members. So the data that you're about to see is a good perspective of what's happening in our state as it relates to those benefit design features. So I'm going to go ahead and turn it over to Holly right now. Bring up the first benchmarking slide.
Yeah, thanks, Renee. You did totally steal my thunder, by the way.
I did or
That's
didn't?
Okay. A little bit.
Okay.
So as Renee was saying, we pulled this benchmarking data from our Oregon membership, which includes about 10,000 small groups, 300 mid groups, which is between 51 to 100, and nearly 1,000 fully insured groups and self-funded groups over 100. And as Renee said, this equates to almost 800,000 total members in Oregon. But before I get started, I want you all to know that we will make this report available to all those who are attending. So it's a little bit of an eye chart, and for that, I do apologize. There's a lot of data on here, but as I said, we will make it available. And this does, I think, does a great job of not only representing, of course, our block of business, but all carriers' block of business as well. Now, as I said, we have nearly 10,000 small groups under 50. In Oregon, I believe there are about 85% of all groups are considered small group under 50. So let's talk about this piece first. So for fully insured groups, the average deductible, and again, we've compared 2016 and 2020. So as you can see, in 2016, most of the deductibles were under 2,000. And in 2020, clearly just the opposite is happening, right? Over half of those groups are over 2,000, and most of those, even some over 25% over 4,000. This also holds true for the out-of-pocket maximums, same type of thing, where most of the out-of-pocket maximums were under 5,000 in 2016. Most are over 5,000 in 2020. Next slide. I think we have this broken up, Brandon. Yep. Okay. Coinsurance and copays. Most people interact with their healthcare with 2 to 3 office visits per year. So copays are really near and dear to your employees' hearts. And as we saw on the previous slide, everything is increasing for 2020. Coinsurance levels obviously are increasing. Copays, the average copay now for small groups is the $40 copay. Now, the days of a zero copay, if you're a small group, are almost over. Next slide. HSAs, as we all know, are gaining traction and are slowly increasing in popularity. We love HSAs at Regence. I'm on an HSA, so they're gaining in popularity. Employer contribution. Now, if you notice, I've got both the beaver and the duck fans covered on this slide. So I had to do that. We just started capturing this data in 2020, so we don't have a comparison from 16. But what I'm really happy to see here in this slide is that most employers are contributing over 70%. The minimum is 50%. And these small groups understand that in order to attract and retain employees, they're pulling from that same pool as the mid and large group folks. They need to pay more than that minimum. And in fact, most small groups are offering employer contribution to the dependents, which, if you think about it, is pretty accurate. Most small groups really do see their employees as family, and they feel that when they're contributing to those dependents as well. So this next slide, what I've done is I'm comparing the 1 to 50 market and then that mid group market, that 51 to 99. The deductibles, as you can see, are very similar. There's not a whole lot of change there from the mid to the large group, but in the out-of-pocket maximums, that's where we are seeing some changes. Brandon, next slide, please. And so in the small group market, most of those out-of-pocket maximums are over 5,000. In the mid group market, you are seeing a significant number of out-of-pocket maximums under the 5,000 range. And this shouldn't be a huge surprise. We do know that as groups get larger, they tend to offer slightly better benefits. And we're going to talk a little bit, we're going to see that too in the large group market. Next slide. Again, copays are near and dear to everybody's heart. As I mentioned earlier, the average copay for small groups is $40, where half of the groups in the mid-market, it's under 20. This is where you're seeing a significant improvement in benefits. And the next slide, we're going to talk about the employer contribution. This too is very similar. Most employers in that mid-market are also contributing between 70 and 90%. And then they are contributing significant to the dependents as well. Now we're going to compare the 100 to 200 and the 200 to 500. I want you to know before I go into this, the full report actually breaks this down by each size. So they'll break it down by small group, mid group, 100 to 200, 200 to 500, 500 to 1,000, and then also self-funded. And we also break it down by industry. So the full report is much more robust. Obviously, we're limited on time here. So we're showing you the areas that we thought were most important, but you'll get to slice and dice any way you want. Okay. For the mid-group market, and this is, I think, where we're starting to see some bigger shifts in the deductibles. So in the 200 to 500, we are seeing the majority deductibles under 2,000. In that, even in that 100 to 200, that kind of mirrors the 51 to 100 market a little bit, where there are some under 2,000, but you're seeing more and more over that 2,000, 3,000, 5,000 mark. Next slide, out-of-pocket maximums. Again, it's going to be slightly better in that 200 to 500, and we're seeing the majority of deductibles, out-of-pocket maximums under that 5,000 mark for that segment, and it's somewhat a similar story in the 100 to 200. Copays, this is where we are seeing, and this slide is a little bit reversed. So you're going to see 0 up top, and then it's going to get to the 40. Again, the blue is 2020, and the majority of small groups, or excuse me, large groups have a $0 deductible. And then we're just going to go right to the next slide. Move this forward. Yep. And in the larger group size, we are seeing employers pay between 91 and 100% more so than you did in the small group market. And nearly all employers in that 200 to 500 paying over 70%. As we can see in the slide deck, things are increasing. More and more costs are shifting to employees. And that's why it's really important to work with the carrier who is trying to get creative and create plans that not only, as Renee said earlier, educate employees and engage them in their healthcare. So hopefully they have an impact on the bottom line costs of healthcare, but also create plan designs and get creative with plan designs and networks. So you are able to offer a different plan design and keep your costs in line with your budget. That's about all I had. Are there any questions?
Well, we do have a couple of questions in the chat, Holly. So let's see if you can tackle a couple of these. The first question was, how many companies pay less than 50% for the employees' families? And I know that depends on the size, but can you kind of generally answer the group that's less than 50%?
Yeah, that's going to depend a lot on the size in the industry. And again, you'll be, when you get the full report, you'll be able to break that down. More white collar groups, we see employers paying more to those dependents. More blue collars, we're seeing even some employers pay zero to the dependents. So that definitely is what a lot of groups and a lot of small groups decide to do, and that groups are not required to make any contribution to the dependents.
Okay, yep. And then the second question is, can you define industry in the survey?
So Renee, I forget, did we break it down by 6 or 7 industries? So it's broken by tech, manufacturing, construction, healthcare, retail.
Yeah.
Okay. Yeah. You know, I noticed in our groups too, we work with a lot of small employers, and it is more common that they may not have any contribution level at all on the dependent portion, or something between 25 and 50%.
Yep.
Is sort of the range we see. I see with your data, certainly with those larger companies, you're getting up in that higher, up above 50% at a greater percentage. So
yes.
Kind of goes along. What's fascinating to me is in the larger group market, you actually are creating your design, right? So the levers is how I like to call them, of how do you look at both co-insurance and deductibles. To your point, Holly, of you want to make sure you're trying to help your employees out as much as possible and get the best bang for your dollar. What kinds of things do you see those larger employers doing with those two categories?
I see it a lot. So, you know, I said earlier that the days of a zero deductible are gone, and obviously for large groups they're not. But for everybody else, that you rarely see a $0 deductible, even for large groups nowadays. So you do see a shift in the deductible. I don't see the shift in co-insurance as much. That co-insurance is one of those things that can be really confusing to groups and members. So they really try to keep that constant. The majority of groups have an 80-20, so where the carrier pays 80 and then the member pays 20. Deductibles, clearly, that's a big one. Out-of-pocket maximums. I mean, the good news with out-of-pocket maximums, as they're increasing, yes, but once you reach that out-of-pocket maximum, and everything feeds up to that, right? So your RX copays, your co-insurance, everything feeds up to that. So once you reach that, everything's covered at 100%. So you have that safety net in place. And then you may see members switching from encouraging members to use virtual health opposed to traditional healthcare, and increasing those type of visits, or offering a zero copay for those types of services.
So Holly, if I could jump in really quick too, I think that when you're talking about larger employer groups too, they have access to their data, and they can see how their employees are using their health care. They can see the levels of how many people are reaching those out-of-pocket maximums. Are people going to the doctors? How many office visits? So they can look at that data and help adjust their plan in order to meet meet the needs of their employees as well as the cost piece of it. So when you are larger, it's so much easier because you've got the data to work with and be able to pull those levers, as you talked, Anne, what makes sense for your particular organization, because everyone is different. And if it is an HSA, what are you doing on HSA contributions, other levers that you can pull? So, having that data is super important, especially for the large employers.
Yeah.
Good point. And large employers, by the way, that's defined at 100. Most carriers will give you data once you get to 100 plus.
Okay. Yeah. And then I think it's also important to point out a lot of our participants may be in that under 50 market where you don't have as much choice on the plan design because you're matching up to those ACA designed plans. Can you just spend a minute on what that looks like and how that works?
So you're exactly right. So we have to have set parameters to be a platinum plan and to be a gold plan, a silver plan. And so one of the things that we're doing is that we're trying to create different plan designs that have a lower cost for those employers, like maybe limiting the in-office visits, but increasing a zero cost share copay for virtual visits, and then a texting on text a doctor type features. So there's
also adding other, just adding in other programs too. So there's these basic plan designs, but what are you doing as a health plan to, help your employer groups? So building in and I was going to talk about this in a minute, wellness programs, care on demand plans, EAPs, and doing all these things so the smaller employer can feel like a big employer. Maybe they don't have control over, okay, it's a silver plan, it has this deductible, but other things that are in my plan that I can access and use that are a benefit. I will tell you, when I came to Regions, I historically worked with very large employer groups and didn't really work in the 1 to 50 market. And I came to Regions, I said, we give all this stuff to our small groups. And so it just surprised me that there is a lot available to a small, you just have to, find out what it is.
Yeah. Yeah. And it's great to hear that carriers are pivoting to try to respond to what, obviously our world is changing, and we're going to jump into that now, but many people are working from home, and there's a lot of new and developing issues that if our healthcare plans can start to move along with the changes in our universe, I think that really is helpful to the participants. So let's dive in there. So the elephant in the room is COVID. So we're in the midst of an unprecedented world pandemic. How is COVID, or is it, impacting what we see in renewals and premium increases? And the second question, what emerging trends can you see related to COVID, and what impacts might there be down the road?
Yeah, so it's been a crazy year and very unique, even in the healthcare space. So if we go back to the beginning of when, basically the country shut down in March, we had a period of time where really routine care, elective surgeries, those things weren't happening. But one thing to remember is cancer didn't stop. Other high cost chronic issues didn't stop. So the highest dollar services were still going on. But we did have a chunk of services that were either delayed or would never, not going to happen. If, I'm going in, once a year, it didn't happen this year, it's going to be next year. So that claim would never happen. So we did have a small group of claims that we know wouldn't catch up, but the high dollar ones were always there. And we saw later in the year and this year is that those claims have caught up. I mean, for the most part, we are we're back to where we were pre-COVID. So, but again, we did have that that piece, and what we did, and other carriers have done it too, is offer a premium credit to our customers because of that. And we thought that was the best approach in moving forward. And our employers responded very, very well. The other thing that, and we brought up too, is virtual care. How a year ago we were begging employers and members to use virtual care because it was a great way to receive care, saves time, money, energy. You have to promote this, come on. And now, explosion. So I have some data points that are very interesting. So in 2019, we had a little over 17,000 virtual care visits. From January to May, just to May of 2020, we had almost 127,000 visits. That was almost 1,700% increase in virtual care. So virtual care is happening and it's here to stay. That is one thing COVID has done that we're not going to go back to the doctor anymore. So that's good. That's good for healthcare. The other thing is behavioral health services. There's been a huge spike in behavioral health, as we all know, because of COVID. We're all dealing with this together, but we've had over a 2,000% increase in behavioral health. And to do it in a virtual setting, our medical director, Dr. Jim Polo, who's a licensed psychologist, said that in his work with patients, they're more comfortable being in a virtual environment than even being face-to-face. So we're going to see even more of that moving forward. Yeah.
That's interesting, isn't it? And maybe it feels less exposed somehow because
Yes.
you're home and you didn't have to get in your car and drive to a doctor's office, and really interesting.
They're feeling they can build up rapport quicker.
Yeah.
And that's super important when you're dealing with, behavioral health issues.
Yeah. And I think about this in the workplace too. Like if people don't have to get in their car or get on public transportation and fight their way through traffic and then figure out, there is an element of this telehealth that is just so much more efficient and cost effective. So those rates go down or away in some cases. That's good.
Yeah, it is. It's been good. It's been good for our industry and good for individuals. Yes.
Yeah.
Well, I know that we've had a lot of physicians too who poo-pooed it and said they would never do telehealth. And they're having to do telehealth and they're like, this is awesome. I'm going to continue to do telehealth when the pandemic is over. This is a great way and method to actually treat patients.
I think it's a bit of a great equalizer too, right? Like people who would struggle maybe to get to those visits now, if they've got an internet connection and they can get connected, it allows healthcare to spread out to everyone in a better way.
Mm-hmm. Exactly.
Exactly. We had a question about confidentiality I don't want to let go by. So Holly, maybe you can address this. It was with regard to when large groups get the health plan data so that they can tinker with design. How is employees' confidential health information protected?
So they don't know who's actually seeking those coverages. So and as an employer, you may know who's going through getting treatment for, say, cancer or something, but that's not going to be on the report. So members are still going to be protected by that PHI.
Yeah.
Renee, anything to add there?
Yeah, there's very specific laws of what can be shared and what can't be shared, and it all has to be de-identified. And if it's even too descriptive, it can't be given to them.
Yep.
So there is significant health information protection, HIPAA laws that are out there that everyone has to follow, whether it be, us at Regence or the employer as well.
Mm-hmm.
So,
Yeah, that's great. Thank you for that. So I'm going to go to the other elephant in the room, which is cost. So we had a couple of questions on the front end of this webinar. So what do you think, and fair or not, we're all, the lay person who is not in the biz may say, well, the costs for the carriers must have come down. Why am I not getting a decrease this year? So talk a little bit about what the way that any insurance carrier, but specifically through the lens of Regions, how do you look at that when you're in a global pandemic, and then how does your underwriters address those issues?
Well, we have crystal balls and or dart boards that work really well for us.
Magic 8 ball.
Yeah, exactly. And the underwriters love it when we talk about all of it. So I think I talked a little bit of kind of what happened with COVID and the premium credit that we and others have given, because we recognize that. But now what we're seeing is pretty much our costs are the same as what they were a year ago now. But I will tell you this, one thing that the layperson may not understand is what we call in the biz trend. And trend is just year over year, the costs of healthcare compared to the previous year. So let's take this example. Let's say you have an employer of 50 people and they received a set of services this year. If you had the exact same people and they didn't age, they all stayed the same, don't we wish? And they received exactly the same services. I mean, exactly as they did the year before, the costs would go up because of medical trend, the cost of services. And medical trends running around 9% and pharmacy trends running around 11%. So doing absolutely nothing, that's a trend, that's the increase in cost. So it's a really kind of important to understand that piece of the underwriting calculation, if you will, not underwriter. But the other important thing to think about is the healthcare dollar. So for every dollar that is spent towards insurance, 86 cents of that dollar goes directly to the cost of care. So whatever that cost is, that's what's going. The remaining 14 cents goes to healthcare taxes and the administration of the plan. And that includes things like customer service, claims payment, the resources spent on care management and case management to make sure the members are getting the right care at the right time and the right services. So all those care management programs that are so important, keeping costs down, that's where that piece goes. So it's important to kind of understand those components when you think about cost, because I think, oh yeah, I mean, everybody's thinking, well, we didn't do anything for months, so everything should go down. So kind of keeping all those components, just like benefit levers, there's a lot of little underwriting levers in there too. So that, yeah.
And someone wisely once explained it to me that as much as, as a negotiator and trying to get the best rate for my business, I always want, to look at every dollar and how do I maximize that. I had a professional a few years back say, if you're ping-ponging up and down in your rates year over year, that's hard on you and it's hard on your employees as well. So sometimes the sort of steady as you go, you don't want to see those large increases, of course, but we're in this for the long game, not this kind of short term, what have you done for me lately?
Exactly.
And I thought that was helpful.
Yeah, and it is, and it's to be with and look for a partner in that as well. And I know that that's what we look for, sure.
Xenium feels the same way. I mean, we like to stick with partners for a long time because it's hard on employees when you choose healthcare, even if you're moving to a better plan with wider coverage. Change is disruptive. So I just think that's another point that we all who are making these decisions need to be reminded of, because the employees, they feel it when we make these changes. So sticking with a partner, I think is always a good idea if you can do it. So
yes, exactly. Yeah.
So I'm going to pivot here a little bit, and this is kind of taking it into another conversation, but we talked about creative plan design. But what are some things that maybe some employers haven't used in the past? They've been in a traditional fully insured program. Can you talk a little bit about some of the trends in emerging plan designs?
Sure. So, but besides some of the things I've already talked about the focus of trying to keep their employees healthy and engaged, looking for wellness services, EAP services, behavioral health services, built into their programs. There we see, and this is more, I would say, on the large end of the market spectrum from your population, at least 100 lives and above, the exploring of what we call funding mechanisms. Yes, most employers are fully insured. That means they pay us a premium and we take care of everything. We pay everything that the benefit plan allows. There are some employers that are willing to take on some risk of payment for their population. And so there's funding mechanisms, on the one end to be self-insured. Basically, you're paying your claims. We're administering them for you. We're doing all the back end work. But if somebody has a claim come in, the employer pays for that claim. But between that, there are different funding mechanisms that are available to the marketplace: a partially self-funded, a level funded, a retro funding agreement. And we could spend an hour just talking or more on each one of those. But depending on how large your company is and how much risk tolerance you have, you can explore those options. And many of the producers, I did a lot of that when I was at Mercer, can guide you through that, ask you the appropriate questions to help see if would be a good candidate for one of those types of programs, if that makes sense.
Yeah. And generally speaking, those type of designs are best suited for larger employers, right? You do need volume to ride out that risk.
Yes, exactly.
Makes sense. Okay. So I'm going to move to another big topic this year, and that is this element of how do we speak to more diverse workforces, right? So we've experienced a continuous push for options that speak to a more diverse workforce. Do you feel carriers are addressing a growing demand for more flexible benefit options or more choices to meet the demands for a wider group of employees?
Yeah, I'll take this one, Renee and Ann. So definitely I see a change. We are serving 4, sometimes 5 different generations in today's workforce. And so, and all of those members are wanting care in a different way, right? So you have the members who want to seek care in the way that they've always sought care, and that's going to the provider's office and seeing him at his workplace. But then you have these members who are wanting the telehealth, as Renee said, that's increasing. The millennials, the Z generation. Then you have people who want to access care through texting, and believe me, that is actually out there. We also see home health care for not only your typical primary care visit, but also for urgent care. So we are seeing and we're embedding in our plans access to all these different types of care methods. So we're meeting members where they're at. And that, I think most other carriers are doing that as well, but that's something really to be conscious of when you're selecting a carrier. How are they transforming? How are they changing with the times too?
Yeah, and I think many of those things you just referenced should help with cost containment too, right?
Exactly.
These win-wins, I always love to hear about those, right? Makes me feel good. Okay, so one trend that we are all experiencing is out of area hiring, right? Like you said, Renee, we're not going backwards in some of these things. And I think a lot of employers are saying, well, my geographic boundaries really are no longer what I thought they were. We've proven the concept. we can work really productively, have a lot of employees working really from anywhere. So can you talk a little bit about out of area coverage, just what you're seeing, what you're expecting, what do employers need to keep in mind from a health design? If they were always in Portland, Oregon, and all of a sudden now they have 5 people spread across the country, or 50% of their group, you know,
Yes.
to the next level, what do you recommend employers think about?
Well, first off, what a great opportunity for employers. It just opens up a wide pool of candidates that you may not have had before. So lots of opportunity, but there are the things that you do need to think about. One thing is you need to make sure your plan, whatever it is, has a good national network. So do they have providers on a national scale? Because you might find an amazing individual that is perfect for your job, but they're located in, Timbuktu, I don't know. And so are there providers available? And then you also have to think about equity in benefit design as well. For example, if a concern would be, let's say you have an HMO here in Portland, how is it going to handle your 5 people in 5 other states? Are you going to have to find a plan for those 5 people? Are the benefits going to be different? Does the HMO have an out of area option? Sometimes they do, but it's not at the same benefit level that's in network, if you will. And are you okay with having a different type of a benefit level for different employees? So definitely things to think about if you're in an HMO, a closed network, a plan. What are those options that are available? First, if the employees can be covered on whatever plan you have, and if they can be covered, what are the levels and what are the cost difference too? Because having just a few people somewhere else could cost you a lot more as well. So really important to, if that's a path that an employer is going to take, talk to their health plan. If I hired a person here, a person here, a person here, what would that do? Where does that land? And nice at Regents, we have the Blues National Network, so we're everywhere. So it makes it so if you have some now and you're considering us as an option, we can take care of you.
Yeah, that's great.
Yeah.
One of the questions that came in before our webinar today was around prescription costs. So I want to hit that one. I'm just noticing the time, so we'll start to wrap it up here. But you mentioned that prescription costs were at an 11% trend, which is higher than the medical trend at 9%. So talk a little bit about what strategies do people have to manage the rising prescription costs?
So I can tell you from our perspective, you have to have the tools and resources to help employees make good decisions, because first, physicians don't know how much drugs cost. Employees don't know until they're at the pharmacy, and sometimes if they're on a copay, they have no idea that the drug's $800, but they're paying $35. So to have tools and resources available to employees to make good pharmacy decisions is just kind of table stakes, if you ask me. So that is super important. And then you have to have a good pharmacy management program to where you're constantly reviewing the new drugs that are coming out, because all the new drugs are the super expensive ones. So to have a good pharmacy management team analyzing those, looking at efficacy, costs, and putting programs into place to help guide people the right way, whether it be step therapy, which is important for members to maybe try certain medications first that have a strong efficacy and a lower price point than something that they've seen on the news. So it's really important. And the other thing is that specialty drugs are exploding right now, and that it's very difficult to get a handle on that. But you combine that with strong case management from a medical perspective with a pharmacy. It's important to have very robust case management and care management because they tie really in strongly with the pharmacy piece of it, but we all have to do our part. Just like COVID, we're all wearing a mask. Let's all do our part. Let's not just think it's only going to cost me 35 bucks when I go get my prescription. Let's ask, is there something more, has better efficacy? Is there something that costs less? And challenging when we're sitting either face to face or virtual with a physician. Do you know how much this costs? Is there a lower cost? Is there a generic? We need to be better consumers and ask those questions.
Yes, I totally agree. And Holly, you gave me a quote earlier a few weeks ago that what's the percentage of prescription that are in the generic range?
It's 88%. But so that's a big number. So most people are getting that generic medication, but there are still a lot of other medications that are being prescribed, either brand or specialty medications. And let me just do one thing. This is not meant to be a Regent's commercial, but let me just toot Regent's horn right here. We internally had a system where we were grading medications, and that's how we were deciding where they're going to fall on our drug lists. And somebody said, let's create a tool like this for our members. So we created a program a few years ago called Med Savvy, and it was just available to our self-funded groups as a rider, but now it's available to all of our groups, including our small groups. And it is an RX transparency tool that not only tells you the retail cost, but your cost based on your plan. It grades the medications A through F, just like school. It gives you the side effects. You can drill down to the entire study. You can talk to a pharmacist. You can put medications in a medicine cabinet and have the pharmacist see if there's any interactions between those medications. Because if you think about it, you could be receiving medications from many different providers. So people have to have access to those tools, and they have to use those tools. As Renee was saying, we really want to get the members engaged in what's going on with their body and what their physicians are actually prescribing and recommending.
Yeah, I think it's a great note to end on, advocacy for yourself and understanding, as you gave the analogy at the beginning, Renee, we all need to understand the cost of everything, more important than our own health. So it's great that the tools and resources are there, because I think a few years ago, people just had to just trust what people were prescribing or saying, this is what you need. And I think we all now know advocating for ourselves and our family members is really an important part of being a good consumer.
Yeah,
So,
exactly.
Well, I want to be mindful of the time. There's one more Q&A. Let me make sure I got to that. Oh, what was the RX tool for pricing called? Holly, can you say that?
It's called Med Savvy. Okay. One word.
And it's on the Regent's website.
Yep.
Wonderful. Well, I want to thank everyone for participating today. Special thanks to Renee and Holly for being a great source of information to all of us. I learned a lot today, and I feel like I'm sort of in the biz too. So thank you for your time. And thanks to all of our participants. We will absolutely get this recording out to everybody so that if you had some things you remember and you want to go back to, you will be able to do that. So thanks everybody for being a part of our webinar today.
Thank you.
Thank you.
Bye.
And there's a survey as well. So fill out the survey if you would for us. All right. Thanks, everybody.